I am recording this from a little trip I'm taking in Key West. Talking about the forehead, and one of the things that vexes us with cosmetic treatments, particularly Botox, and this desire for a frozen forehead, and our desire not to drop the brow or cause a brow ptosis that occurs. About 1 out of 20 people get a significant brow ptosis that they'll complain about. And like a lot of problems, we've got to go back to the literature and see what other people have discovered. So I spent some time looking at this and looking at why does it brow drop in some people and doesn't in other people? What can we do to mitigate that? How important is it to maintain brow position? Well, it's very important to maintain brow position, particularly people that have dermatochalasis. Like I got a fairly low brow. If I drop my brow, I won't be able to see. Then we have people that have a pretty high arched brow where it probably really doesn't matter. If they lose a millimeter or two, it won't matter. So we first had to do pre-procedure patient selection. The ones with a droopy brow really should still stay off the forehead on that first treatment if our goal is to get brow lift. If our goal is not to get brow lift, then we can do stage 2, what I'm going to talk about in a moment. Then we have patients who brow ptosis isn't a concern at all because they already have a high arched brow, and we just sort of want to undertreat the forehead to prevent that completely expressionless appearance, as well as to cause some degree of brow ptosis they didn't otherwise have. So I'm going to tell you what the literature search is telling me. Now, this is mostly in Asians who have a much higher risk of brow ptosis, but we can extrapolate that to Americans, or to non-Asians, to European and African American skin types and ethnicities. But the Asians typically have a short forehead, so they're a higher risk for brow ptosis, about 8%. And what they've done is they found that there's a technique that can be used to weaken the forehead muscles, cause decreased facial expression, get rid of the resting lines or significantly mitigate them with virtually no brow ptosis, and it's called intradermal Botox. So I'm going to talk about that just a little bit. Intradermal Botox, we're talking about with the aqua gold and how it has an effect on the neurotransmitters and acetylcholine, and causes more brightness to the skin, less sebum production, less oiliness, even less redness. There are studies that Botox treats rosacea. But in the forehead, the Botox does get through the skin and into the superficial fibers of the muscles, which causes the forehead lines. Now, I didn't really understand this before, but we have made muscles through our face, and if we inject superficially Botox everywhere, it does affect the muscles to a light degree. But because the muscles are long, they're long muscles, and they attach distally, there's really no effect on facial expression. We do micro Botox to the face, but in the forehead, it actually does soften the forehead lines. Now, a study published in Dermatologic Surgery this year was an elegant follow-up to one that was sort of a preceding, 2 or 3 preceding studies looking at intradermal Botox. So they took women and men, and they grouped them into 2 different groups. One was intradermal, where they would create a skin wheel as you're doing the Botox. Skin wheel, you get the little bump. So using like a 3 or 4 millimeter needle, going at an angle. And group 2 is where they did intramuscular. They went through the skin and felt bone, backed off a little bit, gave an injection. They did 8 units total. They mixed it with the 2.7, so it was, and they did 8 shots. So 1, 2, 3, 4, 5, 1, 2, 3. So mid forehead and above, at least 2 centimeters above the orbital rim. And mid forehead or above. We want to keep it above the lower half of the forehead. And what they found was that they had the exact same amount of wrinkle effacement, exact same. They had the exact same amount of loss of expressiveness. So when they raised their brow, they went down about 80% of their ability to create that expressiveness, and that was the same in both groups. However, there was no loss of brow height in the intradermal group, and there was a statistically significant loss of brow height in the intramuscular group. Okay. Now, other studies have showed it didn't really matter if you went superficial or deep in other muscles. For example, in the glabella, I talked about sticking in a little bit deeper, but the Crothers did a study back in 2013 where they showed that it didn't really matter how deep you went. You couldn't get any more lift by going superficial or deep. It kind of worked both ways, worked the same. But we know that in the lower face, intradermal Botox doesn't really affect the muscles of facial expression much at all, anything noticeable. But in the forehead, because the skin is thin and the muscle is very thin, and it has very short fibers where it attaches into these forehead lines, it has a significant effect. So right here, these lines here are caused by muscles way over here, so I got to inject the whole thing. Whereas these are caused by very local muscles, and it's a different animal. So we're going to start not being so strict on avoiding treating the forehead on that first visit, because that's one of our most common sources of angst is patients go, hey, I can still move my forehead. Well, they want to get rid of their forehead movement. I get it. They want their lines gone at rest, which happens when we don't treat it, but they want them gone more. And the amount of units we use for the forehead is so insignificant that I think one of the things with patient perception is that they're coming in and spending $400 or $500 and they still have forehead lines, where if we just make them kind of go away that first time safer, we will have higher patient satisfaction. When they come back in, we probably don't need to do as many touch-ups. So I'm going to shift that over. I'm going to experiment with using the 2.7 dilution of Botox and microdroplets, and then the 5.5 cc's of saline. We're not going to talk about that right now. I think just go into an intradermal injection with the 2.7, using the small little needle and doing somewhere between 4 and 8 units of Botox above the midline. And then a good safe one is based on the article, which is 5 shots long, a little bit above the halfway mark, and then 1, 2, 3 more shots. So thank you.